Okay, I shall do that. Right, let me just see. Hopefully this is the one. Clickety click. Can you see me?
Perfect.
Okay, well, it's 11:40 on the 16th of March. So we are going to begin our webinar, Breast Medicine Now, with Pink Ribbon. This event is being organised by Pink Ribbon Europe, and we have the support of Pfizer on board. Pink Ribbon Europe is located, headquartered in Prague in the Czech Republic, which is a hotbed of philosophical discourse and inquiry. So I'm going to kick this off with a philosophical question, which is, why are we here? What are we trying to get out of today's event? And I think really we just want to take stock of where we are, 2 years after lockdown and restrictions and all the rest of it, given what's happened in the last 2 years. We want to try and see how precisely breast medicine has been impacted, and how do we begin to make good, if we have to make good, what are the problems, and how can we begin to get things back on track. We have a specific focus, which is looking at policy and priority. So our specialism within Pink Ribbon International is to analyse things from a policy point of view and to put the appropriate pressure on government, policy makers and implementers to move things in the right direction and to do the best that we possibly can, taking soundings and listening to what patients and people are saying to us, and merging that with the expertise that comes from the medical profession to try to really inform policy. What's our geographical range, our geographical focus? As I just said, I mean, technically this event is a Pink Ribbon Europe event. I'm based myself in the UK at the moment. So we're starting that as an initial geographical focus for today's session. But obviously Pink Ribbon is an international campaign. Breast cancer is a global issue. So we're reaching out beyond Britain and Europe to further afield. We also have, as well as contributions from Britain and Europe today, we also have contributions from places like Africa and America. And the idea is to begin that program of activity, lobbying and campaigning worldwide. The specific outcome from this event, we want to create a report called Breast Medicine Now, which we can hopefully finish in the next 2 or 3 weeks, and that can be a starting point for policy lobbying and advocacy. So we need your views, whether you get a chance to speak today or subsequently. Please get involved, give us your input and help us to steer our global program now for breast cancer prevention and cure. So we have an excellent range of discussion points. We've tried to create quite a varied spread in what we're talking about. So we're going to to start off with some initial points about figures and statistics to do with screening and referrals. I mean, I think it might be a little bit too early to come up with a completely exhaustive and conclusive summary of where we are now. The situation obviously has been fast moving and fast changing, but at least we can start to put a marker down as to where things are. As I've just mentioned, we have a range of perspectives from around the world. I think that the biggest question for us to address is where do we target efforts now? I mean, my opinion, for what it's worth, that the biggest challenge in breast cancer, it should be directed towards metastatic breast cancer and finding a cure for that. And it's still something of a scandal, I think, that we haven't made too much progress in that area. I know everyone's absolutely trying their best. I'm getting a little bit of feedback here, and all of a sudden, I'm not sure why. I think that the biggest question for us to address. I can sort of hear myself, but I'm just going to carry on. We have a very interesting section towards the end on terminology and use of palliative terminology in breast medicine, and sometimes getting the terminology right can make a significant contribution to getting the end result right. And we do want to end on a note of optimism and positivity moving forward. Just very briefly, we did a survey just before the webinar to attendees to ask what are your biggest concerns, and why are you here? Why are you attending this webinar? I think funds and delays in research came out as the biggest concern. Obviously, the number of variants, COVID-related variants, that's been a concern to people. It seems to be like an ever-changing situation that we've been facing. And the wish list for today's event is to learn about the latest treatments and ways forward. There was an interesting suggestion from one of the attendees that we can start to create globalized standards in breast medicine. If that's achievable, I think that would be fantastic. But that is a difficult, big ask, but we're going to try anyway. And I know at least one of the attendees today has just recently been diagnosed, and that's the reason for attending as well. We have a range of questions and answers already submitted for the event, and Dr. Kath, our fantastic chair, is going to field those as we go out throughout the day. Just a quick word about the Pink Ribbon Charity. It's an international organisation that is evolving from its origins. It was launched, the Pink Ribbon rather, was launched as a magazine in Britain and America in 1999. It is a work in progress to create this genuine global organisation that would be headquartered in New York. It has been set up there already, and we've during the sort of lockdown times, COVID times, we've set up Pink Ribbon Europe in Prague to begin European efforts. We really do believe, or I do anyway, in the power of a global organisation. I think it would be fantastic once this organisation is finally in place to help link up and join the dots and best practice and networking internationally. And we are also developing a Pink Ribbon Awards scheme to recognise the achievements that we are being made. So I've got one sort of final special request for the attendees. If you can just sort of say who you are and where you're from. If you can do that on the right hand side, I think there's a strip there on the right hand side. So if you can do that when you get a chance, it just gives us a really good idea of where attendees are coming from geographically today. Sorry for the slight slip there. Those are my details. You've got the website address, pinkribbon.co at the bottom. I hope you've found the session enjoyable, and without any further ado, I'm going to hand over hopefully to Dr. Kath, who will introduce herself and help steer throughout the day. Kath.
Thank you, Gerard. Thanks very much. For those who don't know me, my name is Kathleen Thompson for the purpose of this. I'm a doctor, a paediatrician, and more recently I work in medical research. And I had breast cancer myself a few years ago. And despite being a doctor and having all those advantages, I still struggled a lot, grappling with the system, finding people weren't always doing what I felt they should be doing and not knowing how to get them to do it effectively. Plus being in a state of shock. So I felt there's a huge need for a book to help people. And so I wrote one from both ends of the stethoscope, Getting Through Breast Cancer by a Doctor Who Knows, which really goes through how to deal with the diagnosis, the treatment. It explains what cancer is. It tells you what to do if you feel medical staff are not listening. It also explains research and the pitfalls, so it helps you understand articles in newspapers and that kind of thing. And it also talks about diet and lifestyle changes. So that's enough about me, but just to orientate you. Now, Gerard's just explained very nicely and in detail all about the conference, so I won't repeat that in the interest of time. So I'll go straight to the ground rules. I'm sure a lot of you are familiar with Zoom talks, but you'll be on mute during the talks, but we may ask you to unmute yourself when the speaker's responding to your question. We've already received some questions, as Gerard mentioned, but if you have any more questions during the talk, if you can write them in the chat, and then I'll be looking at those, and then when it comes to questions and answers, I'll bring up as many of the questions for the speaker as I possibly can. It's a very tight schedule. We've got some brilliant speakers today from all around the world. So it's really important we do keep on schedule. So forgive me in advance if I have to quickly close anybody out. So I'm not going to say any more. I'm going to start with the first talk, which we're very lucky to have Geraldine Mitchell, who is a consultant breast surgeon from Liverpool, Royal Liverpool. And she's going to talk about the experiences from the Royal Liverpool, screening levels, delays, and the worried well, some practical advice. So hopefully this will be of great interest to anyone suffering going through breast cancer at the moment. Thanks, Geraldine.
So Kathleen, I'm going to try and share my screen. I can't see my presentation, which is great. I may need your help already, Anna, to share the pink ribbon one, because I've got two presentations. Yeah, if you share the pink ribbon one, and then I can share the wellbeing one.
Yeah, sure. Mm-hmm. I see that someone has raised their hand. Gino, I think so. While I'm sharing the screen, perhaps. So I wonder if it's a question or an accident.
Gino, did you want to ask me a question before I start?
No. Okay.
So, just to let you know who I am, I'm Geraldine Mitchell, as Kathleen said. I'm a consultant breast surgeon in Liverpool University Hospital Trust. We've recently had a merger across the city, but I'm also the co-chair of Cheshire and Merseyside Cancer Alliance. You can go to the next slide, Anna.
Mm-hmm.
And actually it's Steve who's done these slides for me. What we've been very aware of through COVID is the fear. What happens? What are we going to do? We don't really know what we're doing. That's medicine and patients alike. But what happens now is what I've been asked to talk to you about. We know that we never stopped treating breast cancer. All through the COVID pandemic, we continued to do surgery, we continued to give chemotherapy, we continued to give radiotherapy. What we did notice, though, was how we did that. We became, in my view, better because we did patient-directed treatments, which were specific for that patient based on their comorbidities, their risks, the perceived risk from COVID, and their type of cancer. As you can see, there was a huge dip after COVID was announced, and we stopped screening. Patients stopped coming into us because obviously they weren't seeing their GPs, they weren't coming in. But what's happened post-COVID, or as we recover, we have had a huge influx of GP urgent suspected cancer referrals. And probably people don't realise, but any cancer referral in the UK is sent as a 2-week, whether it's urgent or non-urgent. So that's a huge number of patients that are coming through our doors. And certainly in the Royal Liverpool Hospital, that's 6,000 a year. So it's a lot of patients. And we've noticed that it's 15% higher in last year than it was pre-pandemic. You can go to the next slide, Anna. But we've also been really, really good at getting our first treatments in. Of course, there was a dip early on in the pandemic. That's what we would expect. But we have tried really, really hard, and we've continued to do our surgeries, as I said, and our treatments. As I said, the treatments became more tailored, and we did use more neoadjuvant treatments, neoadjuvant chemotherapy and neoadjuvant hormonal blockade, reducing the size of the cancer and ensuring that patient got timely and systemic treatment. You can go on to the next slide, Anna. And we were very much afraid that we'd see patients presenting much, much later. And anecdotally, we do feel that we're seeing more patients with fungating cancers or later diagnosis, evidence of lymph node metastasis at diagnosis. But actually, that hasn't been borne out in the figures that we collect. We have seen a reduction, obviously, in stage 1 and stage 2 because screening was paused for that time, but we haven't seen a huge increase in stage 3 and stage 4. Next slide, Anna. And unfortunately, due to COVID sickness, due to staff wear out, due to national and international shortage of staff, Particularly just prior to Christmas, we had a huge dip in being able to deliver that 14-day target. Combination of things, we've just been trying to catch up with our symptomatic service, and we're trying to catch up with our screening service. And we did, in Cheshire Merseyside, we saw a huge dip towards the end of last year. Go on to the next slide, Anna. So screening, nationally, it was never paused, it was never stopped. There were decisions taken locally to pause screening. But now there is some national non-recurring funding to help us support the restoration plan to return to the 36-month round length. So as you know, all patients are screened every 3 years, and we would have an expectation that 70% of our population would be screened. But in many years, and certainly in Liverpool, in a central city centre area, we do struggle to get to that 70%. Now we have a national shortage of radiologists and mammographers, and that's making it quite difficult. Our staff are working almost around the clock, Saturdays and sometimes Sundays, to try and get rid of that backlog. That backlog for Cheshire and Merseyside in November was 32,000. Locally, currently, we have a backlog of 4,550. And currently our uptake is only 64%. I'll try and share the other one, Anna, if it'll allow me. So that's where we are now. So what am I doing about it, or how do I make this better? Just try and do. Can you see that? Anna, can you see my?
Yeah, all good. Yes.
I'll just run down the side actually. So what we've been trying to do locally is try to make people aware that we absolutely understand that having a breast symptom is really, really scary. And patients do have breast symptoms, and patients do have breast pain. And what we have noticed in the pandemic is that patients have been immobile. We've not been able to go out. We've not known what's happening next. So people are scared. And we're trying to educate and empower patients to do the right thing. So knowing you, looking after you, to protect you has been our strapline. So knowing you, are you confident that you know what's normal, what's right? Looking after you, are you your ideal body weight? Are you eating healthily? Are you exercising? We've seen that patients' BMIs has increased in COVID. We're less mobile, we haven't been going out. We've been, I suppose, taking care of ourselves. We're trying to protect ourselves. But that's meant that we haven't been wearing a supportive bra, we've put on weight, our body habitus has changed, and we've become more aware of our body. But have we become aware in the right way? Helping you absolutely helps us. So knowing you, be breast and body aware, know what's normal, know how and when to examine. So the breast it's complex, it's response to hormones. It's not only just on the front of the chest. I say to the medical students, it's not a tennis ball that we cut in half. It extends up towards the armpit, drains into the axillary lymph nodes, but also the nodes in the neck. And it's made up principally of glandular tissue and fatty tissue. So it's going to change with weight gain. It's going to change with hormonal change. Most of that change is normal. So when to examine and how to do it properly, do you know what? You do know you best. And I think we've been very paternalistic in medicine to say, oh, actually, I'm the only one that can examine your breast because I do it all the time and I know what they're like. You wash, you're in the shower, you're in the bath, you have a feel, and we ask you to be more aware of you doing that. So look in a mirror, hands above your head, hands on your hips, look at what your nipple height is. Most patients, the breasts are not exactly the same. They are slightly different. So it's getting to know what's normal for you. Examine in the shower or in the bath, some soap on your hand or with some moisturizing cream when you're lying down. It doesn't matter how you do it, as long as you do it the same way around and circles out radially or up and down. It doesn't matter. And examine in the armpit and the neck, just so that you're aware. I think it's really important to keep that skin in good condition, and doing that makes you more aware of your own body and of your own breasts. So when should we do it? Well, our strapline has been, think for a second, for all of breast awareness, could this be normal? But think for a second, think the second of the month, anyone who's postmenopausal, examine the breasts. or the second week after your period, because we know your breasts are going to respond as you're having normal periods. They're probably at their most premenstrual, excitable form before your period, and we know that. But think normal breast change. It responds to hormones, it responds to weight, it responds to age, it responds to gravity. All breasts will go down with time, and no two breasts are the same. And these are normal breasts. I mean, you'll say, oh, well, those ones on the side, they look really, really big. On the NHS, we don't usually provide cosmetic procedures. So small breasts, big breasts, they come in all shapes and sizes. They're not always the same. And don't forget men. Man boobs respond again to hormones, they respond again to weight. And it can cause a lot of distress and anxiety, not only for females, but for men as well. So what are your true risk factors? Well, your biggest risk factors of developing a breast cancer are being female and getting older. They're not easy to change, but prolonged estrogen exposure, HRT, the pill, family history. But don't forget, breast cancer is really, really common. 1 in 8 of us is going to develop a breast cancer, but it tends to be a cancer of older age. Excess weight gain and how we manage our fat also has an effect on our estrogen. Alcohol intake has been shown to affect it, and a gene defect. But gene defects are a small proportion of the breast cancers that I see, a very, very small proportion. So how do you look after you? Be aware. Know what's normal for you. Try and be that ideal body weight for so many reasons, for your joints, for your hearts, for your general well-being, for your psychological well-being. Take regular exercise. Patients who are under breast cancer treatment, we've probably been the meanest we've ever been. We've said, do not have that extra cake and sit down and feel sorry for yourself. Get up and exercise, because we know that makes a difference. We know that makes a difference in your recovery and getting back to the new normal for you. And attend screening. Like I said, we're only 64% in our local area. We're trying to encourage, it's there. After the age of 70, you can attend yourself. You just have to phone your local breast screening program. Seek GP assessment for something that's persistent. The breasts normally change. They normally change in response, as we said, to your hormones, to weight. When they're not supported, they're going to be painful. We're interested in something that's persistent. Absolutely, we would like to see all breast cancers early, but absolutely, we would like to give more care and attention to the people that need it. And we understand there are a large number of worried well, and we're trying really hard to reassure you. But something that's persistent, we absolutely want to see you. Something that changes the shape, deforms the breast, spontaneous discharge. If we look hard enough for discharge, I will find it. It's normal. It's like your skin's sloughing off, the inside of your duct's still the same. So don't look for it. I'm worried about bloody discharge or copious spontaneous discharge. Try and look, be aware of what you put in your body. Reduce your alcohol intake and stop smoking. Smoking hasn't a true association with breast cancer, but we're seeing increasing numbers of young girls smoking, and the impact on your well-being and lung cancer is huge. So help us. Think for a second. Is this normal? Could it be a normal? Be aware and be responsible. These are the worrying signs, like I said, something that's persistent. It's quite normal to have nodular glandular tissue. I showed you the picture in the beginning. It's nodular glandular tissue is normal breast tissue surrounded by fat. But something that dimples or deforms the skin, something that changes the color, the texture. Nipple eczema is really, really common. If you have eczema somewhere else, it's probably going to be eczema on the breast. I'm worried if it involves the nipple papilla. I'm worried about bloody discharge or copious discharge. And go back to the fact that the majority of our breast cancers occur in postmenopausal women. It's highly unusual to see a breast cancer. It's not impossible, but very unusual to see it in a patient less than 40. And we need to be getting that message out there. And yes, something that isn't right, we do need to see it. And this is what we do. We do triple assessment. This is our unit. You get a history and examination, you get radiology if you need it, but not all patients who come to us need radiology. If there's something specific, we will biopsy it. Pain and discomfort, it's real, but we manage it completely differently to the way we manage period pain. And this is hormonal response. It's a normal hormonal response. We'd recommend anti-inflammatory gel. If you are not wearing a supportive bra, those breasts are not going to be supported, and they're going to be annoyed about that. They're, you know, hanging on your chest wall and they've got no support. So good supportive carrot size bra. Little evidence for even in primrose oil, but some patients find it of benefit, reducing your caffeine and being your ideal weight. Lots of us have seen an increase in our dress size, or someone's been into our wardrobes and shrunk all those clothes in COVID, and we need to be aware and honest about that. It is common. Breast cancer is very common, 1 in 8 women, but like I said, postmenopausal women, let's not forget the men. They're usually present late, to be honest. Early diagnosis, early treatment, but we're more aware of treatment de-escalation. Let's not do something that may cause you harm later on. Let's give a specific, specified treatment for you, your comorbid history, and your breast cancer. We've used more genomic tests in COVID, and we've given much less chemotherapy. And there are lots of people out there to help you, to help us. Any questions? Stunned everyone to silence.
Thank you very much, Geraldine. I mean, I think that was just an excellent talk, and really helping people know what to look for, and B, how to, you know, help themselves as well. Just to repeat one of the questions that's come up, which Asian has already replied to, we are recording this, and the recording will be available and be sent to people. So thanks for that question. I haven't seen any other questions on chat. Please do put some up if you have any. Otherwise, I'm going to ask a question which has been asked in advance about dense breast tissue and mammography. There's been a lot of talk about this and whether other scans are more appropriate, and what should be offered and what is offered in the UK. And I wonder if, Geraldine, you could comment on that.
So I showed that picture, Kathleen, of triple assessment. Our triple assessment has changed, even in my lifetime as a consultant. We now have breast tomography, which in essence is like a CT of the breast. It's multiple mammograms and all put together, and they can give us more information. And our aim is that it will give us more definite diagnosis and hopefully avoid unnecessary biopsy, because a lot of the biopsies we do are benign. Mammogram, as you know, is not great in dense breasts because they're white on X-ray. It shows up as white. So they're not routinely used in the younger patient. That's why we screen 50 to 70, because as you get older, your glandular tissue is reduced and replaced by fat. So it's much, much easier to see if there's a change within the breast. If we know that we're worried about something in particular in a younger breast, so say a patient has a gene defect and is on our surveillance, they will get MRIs. So they're available on the NHS, mammograms, tomosynthesis, MRIs. Ultrasound scan is a very good test for measuring, for locating abnormalities, for helping us biopsy things. It's not a good screening, and it's not a good surveillance tool. Thermography, there's no evidence for it, so I certainly wouldn't encourage people to use it. But remember that breast cancer, the commonest age group is as we get older, and mammogram is perfect for that age group. But when we do assess the breast, if we're worried about something, if we're worried about a specific breast cancer, sometimes lobular cancers can be multifocal or bilateral, we will do an MRI. And that's discussed and appropriately decided for that patient in a multidisciplinary team setting.
Thanks very much.
Question.
Yeah, that's great. And I'm seeing a few comments are coming in rather than questions, which is great. So I would encourage people to look at the chats because I don't have time to read them out. There is one question from Gerard about the shortage of staff such as radiographers, and what do you envisage is the way to deal with that?
So we're a victim of our own success, actually, because if you think about the screening program for us started up around 30 years ago, and that initial group of people are now all coming to retirement. So, and we've become bigger and better, and you know, we've done extended programs, we do surveillance. So we haven't just expanded as much as we should. There are drives. It's a lovely job. They're extremely skilled. Lots of our practitioners now do biopsies, do our mammographic reading, but it is difficult to get people into the profession, to get them into radiology and radiographers. We are trying and always trying to increase our numbers, and certainly in our unit we only have female mammographers because we believe that that's appropriate for our patients attending screening. Do we have male radiologists? We do, absolutely we do. But it's a difficult one. Even internationally, it's very, very difficult to have breast radiologists. And we have become so specialized in medicine. We know more and more about less and less. And we want those people who have that interest and that drive. And sometimes they can be difficult to get.
Thanks, Geraldine. I think just one more question in the interest of time. We've got a couple of comments rather than questions from Joe Taylor, who's going to be talking later today, and it's very much relating to the role of exercise and lifestyle in not just breast cancer prevention, but to help with secondary breast cancer as well. Do you have any comments on that, please?
Absolutely. And we, as I said, we've probably been more aggressive than we've ever been because we know that we make estrogen in our fat. It's one of the ways we treat our breast cancer aromatase inhibitors, or treat or offer people adjuvant treatments. So we do have to have responsibility for ourselves, what we put into our body, how we manage our body, how we exercise. And it definitely has an impact on your well-being and your impact on what you need from the NHS. And I think we do shy away from it, but we all want excellent care. And I'm not saying you should have to work for that, but I am asking that you help us out with that.
Thank you very much, Geraldine. Well, I found that a really important talk, actually, and it's great that it's going to be available. Yeah. And I think we're a couple of minutes early, but I think, Anna, if we could carry straight on with the next speaker. The next session is an international approach, which personally I think is very exciting and interesting. And we've got two speakers, one from Czechia, which is what we used to know as Czech Republic, and one from Ghana in Africa. So I'd like to introduce the first speaker, who is called, I think it's Vladimír Vondráček, who is actually talking, isn't it? It's not anyone else from that centre. And he is the head of the protein therapy clinic in Prague, and he's going to be talking about the clinic. He's also going to be covering policies in the EU perspective on policies, and collaboration across the EU and current statements of treatment. So thank you, Vladimír.
Hello, everyone. It's a pleasure for me to hear me.
Yes, we can. Thank you.
So it's a big pleasure for me to present here our clinical work. It's a bit, say, other part of the care for the patients which actually have already had cancer, the breast cancer, and we are trying to treat them with radiotherapy. So I have a presentation. I will try to share the screen if it's possible. you see the screen?
Yes, we can see it. Thanks, Vladimír.
Okay. So, first of all, let me say something about our center. We are a proton therapy center in Prague. We have 4 treatment rooms, and we are treating the quite wide spectrum of all cancer patients. And a couple of years ago, we started to treat also the breast cancer patients, mainly young left breast cancer women, because we see the advantage of using protons in such cases. So radiotherapy is, this is just a short summary. It's a non-surgical modality for treatment of the cancer. Non-surgical means that you don't enter the patient body. It's treatment from outside, and we are using the invisible radiation to hit cancer cells and deactivate them, which basically means we kill them, or we prevent them to duplicate, to grow. For a lot of cancers, this is a cost-effective approach with high cure rate, and basically maybe 40% of all cancer patients can benefit from radiotherapy in general. In cancer treatment or management of breast cancer, radiotherapy has a stable role, and usually all the patients are treated with photons, with linear accelerators, which are spread all over the world, and this is the usual modality to treat the breast cancer patient. Usually the treatment with the radiotherapy is done afterwards, after the surgery, after actual removal of the tumor from the breast. But as I said, conventionally is used, the conventionally used particle is photon. So usually patients are treated on linear accelerators with photon beam. The proton beam is using the protons as a projectile particle. So we have a quite powerful accelerator which accelerates protons to high energies, so they can penetrate the patient body to the depth we need to hit the cancer cells. Why we are using protons? Why they are more efficient than photons in this case? Protons are charged elementary particle. Charge means if it has a charge, we can modify and change the trajectory of the particle by either electric field or magnetic field. So we can target precisely the protons to the place in the patient body we need to hit. And elementary particle means that it is not breaking into parts. So it is just one particle. It cannot be damaged during passing through the matter. What mean high rest mass? It means that it's a heavy particle, but you have to take into account that the word heavy here is meant in a sense of elementary particles. So it's heavy particle, but in principle it's weighing nothing. But if it has high rest mass and elementary charge, it has a specific dose distribution into the depth, and the particles which are more heavy, they are less scattered in matter, basically in patient body. This is the picture of Bragg peak shapes. The shape of the depth curve, which is called Bragg curve. Now you can see that, well, basically the graph shows how the energy is deposited into the depth of, in this case, water. In the patient body, this is nearly the same because patient people are mostly made from water or consist from water. So you can see that at the beginning of the track of the particle in the patient body, there is a less energy delivered to the tissue, and when the particle is slowing down, and after it slowed down, they deposited more energy in the place we need it. So in principle, we can select the depth where we want to deposit most of the dose. And if we select the correct place, I mean the place where the tumor is, then the irradiation is more effective. This is how our beam looks like on lateral profile. What I want to show by this picture is that the small pencil beam is hitting very precisely the place we want. We call it a set of spots or single pencil beams, and you can see that the width of the pencil beam is a couple of millimeters. You can see here on the graph that the width of the beam is a couple of millimeters, in this case, say 7 millimeters. So with 7 millimeters beams, we are hitting precisely the target of the target, in this case, the tumor site. This is for sure the same for all our patients. And this was just a small physics introduction. Maybe it was not too clear, but I think it was just to display what is the physics behind. And here is a bit of discussion why we are using protons if we can use photons. When we are using protons, we can select the dose, the depth where we deposit the dose, the energy of the particle, so the treatment is more conformal. Down on the slide, you can see two slices, CT slices, where of a patient with breast cancer. The red area is the target volume, the area where the tumor cells are, and you want to irradiate it as much as possible to kill all the cancer cells. But in the very close to this volume, there are so-called critical organs or organs at risk, which have to be somehow spared. The reason is that if the radiation is hitting the normal tissue or the healthy tissue, it can also create some adverse effects, some so-called toxicity of the treatment, and this is the situation we would like to avoid. So you can see on the left the typical treatment plan done by photons, by high energy photons on modern linear accelerator. On the right, you can see the proton plans. The lines with different colors are connecting the points with the same dose, and the colder color is, the lower dose is deposited into the tissue. So here you can clearly see that with photons, you are also delivering quite a high dose to the part of the lung, the left lung, and the part of the heart. Heart is the orange ball in the center of the picture, and the lungs, left and the right lung, you can see there also. So by protons, you can see we deliver quite a high dose to the target volume, but we are sparing heart. We are sparing the ipsilateral lung, in this case the left lung, and also heart veins. Most important is the left anterior descendants vein, which is if we irradiate it too much, it can shrink and it can cause problems later on, and maybe cause also the type of heart. So how we treat with protons, we started since quite large amount of patients since 2018. we have two so-called fractionation schemes. It means how the dose is delivered to the target. One scheme is so-called normal one. It's 2 grays. Gray is the unit of the dose, delivered 25 times, and then we just treating the small volume where the tumor was originally located with additional 8 fractions. So in total, patient comes to our center for treatment 33 times. And in a case we have some, we call it a shorter regime, which means the patient is delivered a higher dose per one session, per one fraction. And in this case, the whole treatment is done in 20 sessions. And as I said, we treated several hundred patients since 2018. So I can say we have a quite good experience with treating breast cancer patients. Our treatment technique is that we are using 2 fields. One is from the front of the patient, and second one is oblique. To be sure that we are really hitting the target, we are really hitting the volume we would like to treat, we use clips as fiducial marker. The clips are inserted during the surgery into the breast, and they are located at in the area where the tumor is, where the tumor was. What we are using next is so-called deep inspiration breath hold, because the treatment itself takes a couple of minutes, and in a case that the patient is breathing freely, then for sure also the chest wall is moving. And there is a risk that during this movement, the beam is not hitting exactly and precisely the target. So we train the patient to voluntarily hold the breath. So the chest wall is not moving during the treatment, and the treatment is more precise. SGRT means that it's called surface guided radiation therapy. We have a specific equipment. It's the stereoscopic cameras that are looking to the patient surface, to the chest wall surface, and we have a reference shape of the surface, and the current situation, current settings has to be as precise as the reference one. So otherwise the treatment is not possible to be done. And sometimes we are also doing, we call it PET-CT verification. I catched a part of the previous presentation where was the discussion about imaging of the patients. PET-CT is another imaging modality which is using radionuclides to display the activity inside the cells and to evaluate if it's a viable lesion or not. With protons, as I said, protons have a particle, so it is able to, proton is able to produce also the radioactive material directly inside the patient body, and then we can display this such places with PET-CT scanner, and then we can easily see if we are really treating the volume we would like to treat. So this is another quality assurance measure to be sure that we are really delivering the dose to the place we want to have it. How the process is done. First of all, we have some team which is deciding whether the patient is eligible for treatment, because some of the patients are not. For example, if they have kind of pacemaker or cardio defibrillator. This is a sensitive electronic device, and it is usually placed close to the heart, which means in the chest area. So there is some scatter radiation, and this scatter radiation can damage the electronics of the pacemaker. So that's why it's not a good option to treat patients with ionization radiation if they have such a device implanted. Then the second step, if patient is found eligible for treatment, we are doing the training of deep inspiration breath hold before even we start any imaging or any other procedures. It really depends if the patient is able to hold the breath for significantly long time. We usually want to have to be able to hold the breath for at least 20 seconds, but some of the patients are not able to do so. So we can optionally do 4D CT scanning. So we do the CT scans in all the breathing phases, but it includes also that we have to make the target volume bigger to be sure that we have it all the time in the beam. So very preferred is the situation when the patient can hold the breath. Then the CT scan is performed in treatment position. Treatment position is that the patient is lying on in a supine position with hands above the head. So there is nothing in the way of the beam for the treatment. Then the treatment planning is done. The pictures I have shown are from the treatment planning system. So we somehow calculate how the breast wall must be irradiated. So we set up the beams, we set the intensity of particle pencil beams, evaluate the dose distribution, and if we fulfill all the constraints we have, so we are sparing the organs at risk enough, and if the target volume is covered well, then we do the last pre-treatment step before actual treatment commences. We do the pre-treatment simulation. So we put the patient again on the CT scanner to check the position, the shape, and the situation in the treatment area to be 100% sure that we will be treating exactly what we want. And then the prescribed number of treatment sessions is done. As I shown in the slide, 2 slides before, it depends if it's 25 plus 8 or 16 plus 4 treatment sessions. So the patient is coming to our center to do the imaging, to do the training, then the treatment planning and pre-treatment simulation and pre-treatment QA takes some time. So so at least 1 week is between first scanning on the CT scanner and actual start of the treatment. And then patient attends our center every day, every working day. We don't treat on weekends. So if the patient has 33 fraction, it means he is coming to our center for 7 weeks, basically every day. Just a couple of words about treatment outcomes. In general, as I said, we treated several hundreds of the patients. Maybe it will be more than 1,000 this year. So the patient usually tolerate the treatment without major problems. Sometimes, as I already mentioned, the compliance with deep inspiration breath hold may be a problem. Sometimes it happens that patient looks fine during the preparation phase, during the training. He can hold the breath for enough long time, but during the treatment his status may change or something may change, and he is not able to hold the breath hold the breath in the face as he was able during the training. So we have to do retraining outside of the treatment room, and for sure in this case we have to do the replanning. We have to also create new treatment plan and do the new treatment verification again. Usually what is visible on the patient when you treat the patient with radiotherapy is some skin effect. It looks like a sunburn, and we call it acute skin toxicity, and this is usually mild. But for sure, if the tumor is infiltrating the skin, so the tumor is growing into the skin, we cannot spare the skin as a critical organ, and in this case, it's a target volume. So in those cases, there might be clearly visible the acute toxicity or the acute effect of the treatment on the skin of the breast. And there is one slide which tries to somehow reflect the current situation, and with epidemic or pandemic situation with COVID, for sure we were also hit by this quite hard. For sure, in general, the treatment is adequately effective if the schedule is maintained. So, as I said, if the patient is coming, has 33 fractions, it should be delivered 5 fractions per week, not less, not more. Then we can estimate what will be all overall treatment outcome. If there are some interruptions in the treatment course, then the tumor control probability is somehow compromised. So our main aim is not to interrupt the treatment. With COVID, it was quite difficult because if the patient was simply become positive or he was at risk of being positive, then we have to make a specific measures. We treated patients even if they were positive, but we have to, well, if he was positive and he felt good enough to continue and undergo next treatment session. So if they have a mild COVID, then they were entering the treatment rooms as the last patients at the very end of the treatment day to eliminate the contact with other patients. This was one of the key measures we have to do. Basically, we did not interrupt the treatment because the interruption creates probably higher risk than the risk of COVID for other staff or people when you manage the situation well. So if the patient becomes positive or he was at the risk of being positive, then we put him to the end of the treatment day, so to not to be in contact with other patient. The room has to be disinfected for sure. We dedicated the staff group to take care of those patients. So these staff members make a specific shift that do not work any other part of the day, and they were not in contact with other staff members, because for sure if a lot of people who are taking care about our patients will be positive or ill, then we cannot provide the treatment anyway. So for sure, if some of the staff member has symptoms, that they are not allowed to continue in work, not to spread the disease further, For sure, we have to wear protective mask all the time. And also in a case of positive patient, they have a specific dress, protective dress. And regular disinfection of surfaces and workplaces also performed.
Vladimir, sorry to interrupt. We're getting a little bit short of time. Have you got?
I guess this is the last slide.
Fabulous, thank you.
As I said, this is the last slide. This was last access information. So thank you for attention.
Thank you so much, Vladimir. Well, your talk certainly stimulated a lot of questions, so I think a lot of people are very interested in this. I'm going to introduce the next speaker, and then we'll take questions for Vladimir at 1 o'clock after the two speakers. Is it all right for you to stay for that, Vladimir?
Yes. Well, basically, I have to leave in 20 minutes. So.
Oh, that'd be fine. We've only got a 10-minute question slot, so that would be perfect.
Okay.
I'll make sure your questions go first. Thank you.
Okay, thank you.
Okay, now I'd like to introduce a consultant breast surgeon from Ghana to give us really another completely different view on treating breast cancer in a different part of the world with different challenges. Dr. Mrs. Beatrice Wiafe is president and founder of Breast Care International, and she's also consultant breast surgeon at Peace and Love Hospital. So we'll hear her talk, and then we'll hear questions and answers from both speakers for this session after this at about 1 o'clock. Thank you.
Thank you so much, and thank you to all the organizers for inviting me to speak here. And so we are going to see a different perspective from what we've heard so far, because we are seeing palpable lesions and we are seeing very advanced stage breast cancer. So I'll be giving the view from Africa, even though I'll be presenting from Ghana. So what has happened and what needs to happen? The control of cancer is best brought about through a combination of cancer prevention and treatment. It requires significant infrastructure, manpower, and normally it's very expensive. And even the resource-rich nations have difficulty providing adequate, high-quality treatment to all of their population in need. And so for those of us in the low and middle income countries, we think our best bet, our best option is prevention, especially preventing the late stage disease that we always see. We've heard about the incidence worldwide, and what I want us to note is the fact that according to WHO, over 70% of cancer deaths occur in the low and middle income countries, and we form majority of these countries. Most of our women are diagnosed relatively at younger ages. If we have about 58% of our patients below the age of 50, it makes breast cancer not only a matter of public health concern, but a developmental issue, an economic issue. In 2020, according to GlobalCan, about 4,050 new cases of breast cancer was diagnosed. You would think it's not a big figure, it's not a big number. These figures have our loved ones behind them. And you should look at the fact that about 2,020 of these died. So our mortality rate is high. Please forgive me for showing the following slide, which is of very advanced stage disease. And these are the cases we see on regular basis. In fact, about 60 to 70% of our patients come in these late stages, whether it's the man or the woman. But of course, women are more than the men. So Dr. Martin Luther King said that our lives begin to end the day we become silent about things that matter. And that is why in 2002, we founded Breast Care International to create awareness about breast cancer among the population, improve the diagnosis and treatment, advocate for acceptable screening and treatment modalities. We don't have screening mammography. We don't have it. So all we have is to train our nurses, our healthcare professionals, how to do clinical breast screening. And that's why I said we are diagnosing mostly palpable lesions. So the Breast Care International aims at also increasing the survival rates, reduce morbidity and mortality, establish a database for breast cancer through research. And there has been a lot of research ongoing. I must say here that I thank the Royal Marsden Foundation for similar research that we did. Training of manpower in oncology. To also fundraise to support needy or the vulnerable breast cancer patients and survivors. Why do we have so many late presentations? There are myths and misconceptions surrounding breast cancer. People think it's not curable, of course, because majority of them go late to the hospital. So the notion is that it's not curable. They think it's caused by witchcraft. They think it's a spiritual disease, and that is, it's by fate that a woman will develop breast cancer. They think it's as a result of a curse on a family, especially when you have positive family history cases. They think it's as a result of the woman's failure, and that women die from mastectomy. Because of these negative things, breast cancer is still stigmatized in our part of the world. But the woman has to overcome a lot of barriers, lack of awareness, inadequate or bad treatment. The cost involved in treatment is huge, above what the average woman can afford. The distance, all the treatment centers are in the cities. So the woman has to travel for hours, between 6 to 8 hours, sometimes more than 10 hours, before she can get to a center where a simple diagnostic mammogram can be done. Lack of counseling. We don't have counseling units in all the treatment centers. Lack of support, to the extent that sometimes husbands even run away from their wives when they are diagnosed with breast cancer. It's all part of the lack of awareness. So we start telling our people that breast cancer is no respecter of persons or profession. You have lawyers, you have doctors, police women, farmers, traders, the fact that teachers, everyone, every woman is at risk. We also take advantage of the media, the vibrant media. So the media helps us a lot in educating the people and creating awareness. We teach our women how to do their own breast self-examination. In certain settings, breast self-examination is not relevant, especially when you be having non-palpable lesions. But in our setting, it's very important. So we teach our women. We also use this model where the Breast Care International will be looking at the community, the screen and refer, creating awareness, and then the Peace and Love Hospital, which is a sister hospital. That's the diagnosis and treatment, palliative care, survivorship, reintegration, and all that. We go out to the communities, to the churches, to the workplaces, to the schools. We believe that if we educate the students, they will grow with the knowledge, and they will help us to educate their mothers, their grandmothers. After the education, we do clinical breast examination, where we look out for these kind of lesions, lumps, abnormal discharges, changes in the breast that the woman may not identify herself. And sometimes people think that it's only when there's pain that they have to go to the hospital. Once there's no pain, they think there's no danger. So we do these screenings in the community to help them, to help identify early stage disease. We've been doing these nationwide yearly walks for the cure. We started it as a Susan G. Komen Ghana Race for the Cure. And after the second year, we turned it into the BCI Ghana Walk for the Cure, where we gather women, men, students, children who can walk to come and join us and to walk for the cure. We've been having our presidents, past presidents, our first ladies, and in 2017, we have our first lady walking with us for the cure. In 2019, we had the last walk because COVID-19 came to interrupt us. So in 2019, we had 43,000 people walking for the cure. Our walks are not for fundraising. They are mainly for awareness creation. We realized that the educational levels are low. So we started training our people in basic oncology, training for the nurses in the communities, training the media. Our media is so vibrant when it comes to football and politics. So we decided to train them in basic knowledge about breast cancer and cervical cancer. And sometimes we add prostate cancer as well. The breast health promoters who happen to be the spouses of Presbyterian ministers. And we plan extending this to other churches. We also trained our survivors as peer navigators. So they will share their stories, their personal experiences with the newly diagnosed women. And this program, we call it the HOPE program, has been adopted by the Advanced Breast Cancer Alliance as a toolkit. We've also been trained the young ambassadors. So the breast cancer survivors were brought together, and it was all to improve the quality of life of the survivors, and also to bring together those who have survived it and to serve as, a mirror for the newly diagnosed ones. It gives hope. It helps to demystify breast cancer and remove the fear surrounding it so that other women will know that we have people who have survived the disease. So we have fun during these walks using our Breast Care International's ambassadors who are musicians and people who we call them influencers. We normally also work with the survivor babies. These are children whose mothers are survivors or who have lost their mothers to breast cancer. Sometimes some of them drop out of school, and so we need to look for them and help them to integrate and go back to school. We do, sometimes we gather them, get materials from the Ghana Textile Print, GTP, and then we, sew it for the survivors to have fun, so we do photo shoot for our breast cancer survivors. Through these programs, we were invited by President Bush and the wife, Barbara, to join the panel to discuss the pink ribbon, red ribbon at the Bush Institute. We're also invited by President Joe Biden and the wife to dinner in the White House, which we see as a pat on the shoulder. Our partners, Direct Relief, has been sending us donations of, medications and equipment, which we in turn donate to other hospitals and clinics. And they has been going on for years now. We are grateful. I want to show the picture of a survivor who gave her consent when she came to us. This was the first day in the hospital with this huge tumor. And she had been going from one prayer camp to the other, one herbalist to the other, until she got to us. We decided to give her the chance and did mastectomy, chemotherapy, radiotherapy. And after that, she has relocated from the central region of Ghana to Ashanti region to join Breast Care International and the Peace and Love Hospitals. She's now a member of our staff, and she has volunteered her life to show her scar and her prosthesis during our outreach programs. So we say breast cancer has been exposed. There are a lot of activities. We say, what's the way forward? We should continue with the education and awareness campaigns and the screenings. The training for the nurses and peer navigators should be ongoing. Education should be a dynamic process. We also have a program, the Bus Stop Cancer Project, where we think that we should educate our people at the bus stops, the bus terminals. I'm going to show a few slides on that. Support for the poor breast cancer patients and survivors. If we need to have survivors, more survivors, who will help us create more awareness, demystify the disease, and also to encourage more women to report early to the hospital, then we have to support them to go through their treatment. We also have been providing audiovisual documentary, which sometimes are played on the buses. So the Bus Stop Cancer Project, I want to touch briefly on this. This is a typical bus terminal in Ghana. And you see how it's crowded with the buses and so many activities. Another bus stop. And so you realize that these patients do not have time to even go to the hospital for screening or to go somewhere to get themselves checked. And most of these women, these people who patronize the buses are women, because they travel to, go and buy things from point A to point B to sell and to make money to support their families. A lot of these women are single mothers, so they just have to work. And so we are thinking of getting the right equipment for that program. So this was a program we did. And if you see behind me, that is an improvised closed tent that we were using for the breast screening, because we don't have a closed tent for use. This is the type of tent we are talking about, which we need to purchase for the activities for the the Bus Stop Cancer Project, with an air conditioner, because it's always very warm. The temperature is normally around 30 degrees. So you cannot use a closed tent for screening without an air conditioner. We need the PA system to use for the education, so that if the woman is even engaged in something else at the bus stop, she can hear what we are saying. She can listen to the education that will be given and the awareness creation. And we want to get this kind of setting where this was seen from the Church of Pentecost, their national convention, where they provided a closed tent and an open tent for the education. So this is the setting that Breast Care International wishes to procure. And so members on this platform, if you think you can help us to get this setting for the awareness creation, please don't hesitate to contact us. I think the organizers and Geraldine will be there to help us to get the right people to support us to do this kind of job that is necessary. So there are a lot of research gaps also in survivorship in the low and middle income countries, and we are ready to do collaborative research in survivorship. And for the subtypes of breast cancer, we have majority of our women are with the triple negative disease. And we are aware that is one of the difficult subtypes of breast cancer to treat. And so, but we know that if we find them early, we can manage them well. There's no social support system in our part of the world. So for the vulnerable women, it's important that we do some fundraising for them. If you visit www.bciamerica.org and you hit the donate button, you can donate to BCI America, which will be used for the activities in Ghana for Breast Care International. And in my conclusion, I want to say that it behoves on us as those who can make a difference to do everything in our power to save as many lives as we can. Let's all join in the fight. We are stronger together. And please visit our website and just share your views, ask your questions if you are not able to ask them now, and let us do what we can to help our people. Thank you so much. Thank you for inviting me to share these slides with you.
Thank you very, very much, Beatrice. I think everybody is sitting here quite stunned from your presentation. I mean, those pictures of Late's presentation were really quite shocking, and the steps that you've taken to address it are really just quite incredible, and I think we're all in awe of you, quite honestly. If you can hang on for the question and answer session as well, I've got some questions coming in. I know Vladimír needs to leave quite soon, so I'm going to deal with Vladimír's questions first and then go on to your questions, if that's okay. So, yes. Vladimír, you're still here, are you? Vladimír, are you on mute?
Yeah, he's on mute, but I can see him.
Okay.
Okay.
Okay, so I do it all the time. So Vladimír, questions for you. One question is the efficacy of photon therapy for multilobular breast cancer, where obviously there's not just necessarily one solid lump, but there might be lots of diffuse lumps. Is it suitable for that?
Well, basically all the patient cases which are eligible for photon radiotherapy can be in principle treated with protons. This is I guess a general answer, but we really evaluate each patient case about the eligibility of the particular treatment approach. Sometimes we can see big difference, so these patients can clearly select where to get treatment. Sometimes, but usually the proton treatment is more or is better from the point of view of dose load to the healthy tissues. If you treat with photons, you are treating a lot of healthy tissues as well, and with protons the treatment is more conformal. So this is how we usually evaluate it.
Okay, thank you. Now, I know that at your centre you treat a lot of people internationally, both within the EU and outside the EU. And there's a question on this, your view on international treatment and ease of movement.
Yes, we do the treatments. We have in the EU here we have some kind of international possibility of insurance of the patient. So for a lot of European countries, there's a possibility for patients to come here, and there is some, you know, paperwork, and usually their insurance company will pay for the treatment. For sure we can treat patients. We treat a lot of patients from UK as well. We treated a lot of patients from Slovakia, for example, which is the country with the highest number. I mean, the Slovak people are the most frequent minority in our cases, because major of our patients are Czech patients.
Thank you. And then one final question, a slightly sensitive one, but one of the delegates actually asked about protein therapy at her local hospital, which is a large cancer centre in the UK. And she was told that the research hasn't been complete yet for breast cancer, and so she was not offered this treatment. And she'd be interested in your comments.
Well, as I said, it's hard to make any comments on a particular case, because as I said, we evaluated on individual basis. So in principle, maybe for some reason they do not offer them a proton treatment. This is really hard to say. I cannot say why colleagues in different hospitals makes such a decision.
Okay, thank you very, very much, Vladimír. I mean, I'm sure we've got more questions, but it's been an excellent talk. I know you've got to go now, so thank you very much for sharing that with us. Really appreciated.
Thank you very much for inviting me, and take care.
Thank you. Now going over to Beatrice and situation in Ghana. I mean, I think first of all, I'd just like to say that I think the work you're doing, Beatrice, is amazing. And you did share the details about your charity, which, I mean, I don't think anybody would argue is a very important charity. And perhaps if we can have those in an easy shareable format somewhere, Anna, and if delegates would be willing to share this on social media, I'm sure this would help Beatrice a great deal to try and get some funding in. Now we've got a couple of questions. The first question is about taking on board the cultural values and belief, which you explained so very well in your talk. I mean, obviously it's hard anyway in a country where distances are big issue to educate, and I know you're doing a great job with education, but some of the beliefs, I know you've talked about this a bit already, but maybe you can expand on what's almost the quickest, easiest way to address these barriers to people seeking treatment.
Yes, thank you so much for this. It's actually very important to try to change the cultural beliefs of people and the way people do things. And you understand that it's not easy. It can take a generation before some beliefs can be wiped off. And let me give one small example. We went to a school, a senior high school recently, and one lady was asking a question that when the breasts are coming, normally they apply some insects to your breast so that it can help it to develop bigger. So would that have effects on them? And I was shocked because when I was also a teenager, in fact, when I started developing breast, that was the things we were doing. They were giving us insects to apply to the breast. And this is a generation that can be at the age of my granddaughter, and they are still doing it. So it means that it's being passed from one, generation to the other. And it will only take education and awareness creation to make things happen the way we want it, to change the narrative. And that is why I believe that we should concentrate on the children, the schools. And if we are able to start the education even at the junior high school level, so that they wouldn't believe that breast cancer is caused by witchcraft. by the time they grow up, because they can now go to the internet, they can Google for information, which was not there previously. And also in the older generation, a lot of women cannot read nor write. The educational level is too low. And so people just get information from what hearsay. And so we believe that with time, things can change, but we need to act as catalysts to cause the change that we need.
Thank you, Beatrice. And then there's one final, it's kind of a question and kind of a comment, but I think it's quite important. And it's from somebody in East London, initials SS on the chat. And what she's saying is that in her area of London, it sounds from what she's saying, I'm interpreting, as if there's a large African community there she's dealing with. And she's saying that those kind of late presentations that you showed, they're also seeing actually in East London. And she's been working with a radio station called Voice of Africa. So I think part of the question is relating to fundraising and your approach. And I also think if you're willing, it might be very good for you and this lady, and sorry, I only know the initials SS, but SS, if you can maybe make contact with Beatrice and you can get together, because you might well have a lot that you can share information on that.
Yes, I'll be happy to collaborate, have interactions, because we've been also doing a lot of radio interviews. And you see, if I read the comments, these are old people with comorbidities. So if they have advanced stage breast cancer, it's probably because they couldn't diagnose them at the right time. They couldn't give the right treatment because of their condition. But we are talking about young women. We are talking about women in their late 20s, in their 30s, and in their 40s. Our mean age is 43. And so breast cancer strikes earlier. And like I said, our subtypes are more aggressive, grade 3 tumors and triple negative disease. And so we should be more aggressive in our awareness creation exercises and make sure that our people report early. And I also mentioned that when there's no pain, our people think there's no danger. And we know breast cancer doesn't start with pains. And so we have a difficult task on hands, and that is why we are asking everyone to come on board and join us to change the narrative in our women, because women are dying needlessly, prematurely, leaving their young children because they didn't come to the hospital early.
Thank you, Beatrice. I think you make a very important point about the fact that it's often young women as well, particularly in your demographic. But also, I think it's important to remember that young women, although it's rarer, can get breast cancer in any country. And a woman should never be ignored, whatever her age, if she is concerned about her breasts. And also your important point in the talk about men can also get breast cancer. And I think we can't forget that either. I'm going to have to finish this now because it is the lunch break, but thank you again. And I think there's been a lot of chat messages to you about contacts for supporting the charity. So I wish you every good luck in the world with this. So we've now got a break until 1:40, and we do need to come back promptly, I'm afraid. During the break, the Zoom will be open, and you can either chat to people publicly, or there's a private facility just to chat to people that you want to chat to as well. And also Rufus Greenbaum has asked Gerard if he can put up a slide on something he's interested in with vitamin D. So there will be a slide up to see. So in the meantime, grab something to eat and drink, and see you back at 1:40. Thank you to everybody, both delegates and speakers. It's been excellent and real pleasure to meet you all.
Thank you.
Thank you all. Rufus, I can see that yes, you took over. Did you want to keep your slide for the whole lunch session? Rufus, you are on mute. If you let me unmute. Hi, Rufus.
As much as you wish. It can stay there if you wish.
Right. Okay. So I do have a slide, just like a placeholder with the schedule for the afternoon session. So let's agree that maybe we'll keep your slide for 10 minutes or 5. Gerard, did you say 5? 10?
Yeah.
As you wish. As you wish. It's a very simple message.
I think also I'd like to add a disclaimer as well, that this slide is from Rufus and it's not necessarily the views of Pink Ribbon or the other speakers. You know, I think that's important. They're
well,
it's
all I'm doing is inviting you to go to this place to research it for yourself.
That's absolutely fine. But as I say, I do think it's important to hear that this isn't actually part of the.
No, that's fine. That's fine.
It's just a request that's been made. Okay. Right. See you all after lunch. Bye now.
Thanks, Kath. Rufus, are you there?
Yeah.
Just introduce the slide, please, if you can. Just the content of it.
Well, from Vitamin D Wiki, which is the website that I'm showing at the bottom, they list the 22 meta-analyses of vitamin D and breast cancer. And the overall reduction, the overall message is that if you have breast cancer, if you boost your vitamin D to the right level, you can halve the risk of death. And if you haven't had breast cancer and you boost your vitamin D level, you can reduce your chance of getting breast cancer by 3 times. Now, some of the genetic variations, the BRCA1, 2, and 3, this may not apply, but overall, it's a contributory thing as part of your diet and lifestyle. It's not a monotherapy, it's not perfect, but I invite everybody who's on this Zoom webinar to research it for yourselves. That's all.
Okay, that's great. We can just leave it up then for another minute, and then I know you can put the holding slide up for lunch.
Okay.
And I might even go and grab a cup of tea myself. Thanks, Rufus.
Hi, everyone. while we are waiting for the kickoff of the afternoon session, Alex, I think I can see you among the participants. You will be presenting the second in this session. So I wondered if you are presenting, feel free to share your slides yourself. But just in case, while you're waiting, you can send them to me in case there are any technical issues.
So I will be very honest with you. I wasn't aware that I was meant to have slides.
No, you are not. Yeah, only it's up to you. So it's up to you.
Yeah. And the other thing was also about the time slot. What I was aware of is that it was going to be a discussion with questions during this time slot from 1:40 to 4:10.
Right. So today, there are at this session, there are two speakers. So Jo Taylor is actually not joining, but I will be sharing her video that she recorded last night, and then it would be your time for you to share your thoughts. So and then shortly after we'll be just moving on to the discussion. So it's all very flexible and
great, because we only have 30 minutes.
Correct.
Yeah, and we already received some questions, and just answering those can take, if we want to go into that, it can take some time.
Yeah, exactly. Yes, and usually it's a very lively discussion in the chat. So definitely, yeah. Very good, very good. So we'll be waiting for the chair, Dr. Kath, to kick off this session. Thank you.
Okay. Typical efficiency, Anna. We'll start a minute early. Right, so I hope you're all back. I think the session this morning was just excellent. We covered a lot of ground. For the sessions this afternoon, we're kind of almost looking at the future. And the session 3 is got two speakers. It's got Jo Taylor, and she's a patient advocate who she'll tell you about herself, but she's got secondary breast cancer and had it for a number of years, and knows a lot about advocating for patients, amongst other things. And so she'll be concentrating on what we need and how to get it. And then very excited about the talk from Alex Filipovic, because Alex is at the very forefront of research into cancer treatments. And I'm looking forward to hearing what the horizon's looking like for breast cancer. And then we'll have some more sessions after that from different clinicians, but I'll talk about that later. So starting now, Jo unfortunately isn't going to be here for her talk, although she will be here for the questions. So Anna's going to show a video that Jo's prepared, and then we'll go straight into Alex's talk, and then we'll have 5 to 10 minutes for questions at the end. Okay. Thanks, Anna. You're on mute, Anna.
Mm-hmm. Yeah, very good. So right now you can see the website of Pink Ribbon, and this is the, oh, sorry, loading.
Hi, sorry I can't be with you just at this moment. Hopefully I'll be joining later. My name is Jo Taylor. I am the founder of 2 organisations called After Breast Cancer Diagnosis and METUP UK. As a patient advocate, I can see the many issues that there are living with this devastating, incurable illness and being ignored and invisible. Secondary breast cancer has to be highlighted. It is the biggest killer of women with cancer under 50. In the UK, 31 women die every day. That equates to around 1,000 a month, 11,500 every year, and there are 80 men who die of secondary breast cancer as well. We want to survive longer. We need improved outcomes for secondary breast cancer patients. There is a total lack of awareness of secondary breast cancer as it is ignored, and there is no awareness campaign about the disease like there is for primary breast cancer. GPs understand secondary breast cancer, and patients with primary disease can be ignored due to a lack of understanding. I created an infographic to show where patients will develop secondary breast cancer, and the NHS in England is now signposting to this important document. Pfizer have supported this document to be translated into 11 languages, so there will be awareness worldwide. There needs to be an uptake of the infographic and for it to be used within the whole of the UK. There is an end of treatment summary report that was created in Greater Manchester Cancer that includes the infographic, which is shared within NHS England, supporting awareness for patients. The document is also shared with the GP via Gateway C, which is a portal for GP learning. Again, GPs need to be aware of what to look for patients instead of sending people away, especially if those have already had primary breast cancer. In England, there are many things that need to be improved. This is around awareness for secondary breast cancer. Women just don't know these red flag symptoms, as many patients have shared their experience with me. We need speedy access to effective drugs. We need to be counted and data needs to be collected, as there are no figures for those who are living with secondary breast cancer, as highlighted recently in a BBC report. We don't have true personalised care. Not everyone has access to specific radiotherapies, surgeries, and genomic testing is not standard for every patient every time they progress with the disease. We have restrictive treatment lines, and we cannot go back on treatments if we progress. We all need all the drugs to be available to use them effectively within a toolbox of drugs. We need better access to clinical trials and an easier way to access them. Met Up are creating a database that make sure that all trials for breast cancer are collected into one document, because there is a problem with this and not having visibility of all the clinical trials on each database. Clinical trials have many restrictions to access, and we have limited access to trials due to the amount of chemotherapy patients already have had. If they've had numerous chemotherapies, it sometimes makes us ineligible for trials or trial access. I've campaigned for over 8 years about the lack of data. It was mandatory around about 15 years ago. Now an NHS audit has been agreed, but this won't provide data until 2023. Tenders will not be agreed until after October 2022, and then they have to start collecting the data. We have a 2 to 3 median life expectancy, which means some patients won't even be alive to see these results. If no data is collected, we have a lack of support due to no access to funds, not enough clinical nurse specialists, no services to support patients. How do we know what drugs are needed? How do we support secondary breast cancer patients with clinical trials? We need more services like radiotherapy and surgeries. We need more investment to survive longer. If we don't count patients, how do we know if survival is improving? We need to measure outcomes, as there are no measures. We've watched a pandemic unfold and all the figures and statistics that were produced. COVID patients who are living with COVID are counted, and we know how many die from COVID, but we still don't know how many are living with secondary breast cancer. We just know that 31 die every day, 1,000 a month, 11,500 every year. We demand change. Thank you.
Well, in Joe's absence, thank you very much for that, Jo. I mean, as usual, she's given a very concise and to the point talk and covering some very important issues, which we will discuss further in the Q&As when I'm hoping she'll be back. And I'd like to hand over to Dr. Alex Filipovic, who is Honorary Clinical Research Fellow at the Department of Surgery and Cancer, Imperial College. And as I say, I'm very much looking forward to her talk on drug markers and trials and looking at a more robust system.
Thank you very much, Kathleen, and welcome everybody to this session. Thank you for your time. I'm really pleased that we kicked off this particular session with patient advocacy, because we all always need to be grounded and reminded that what we do is always about the patient and only about the patient. I'll give a very short personal intro. As you said, my name is Alex Filipovic. I have always throughout my career combined clinical practice with research. Very fortunately, at the start of my career with basic and translational research, which has just had its natural progression into now doing clinical trials and combining that with active clinical day-to-day practice. And I'm very happy to be doing both, because on the one hand, we get very, very grounded in real life clinical practice with patients. And then there is so much hope and awareness of all the progress that has happened in the field of oncology, especially in the past 10, 11 years. And we see it coming into the practice that we can offer to our patients. So I would kick this off by saying that we have witnessed a really profound paradigm shift in the field of oncology with the entrance of immunotherapies into the cancer treatment paradigm about 11 years ago, with the approval of ipilimumab in 2011, and then approvals of anti-PD-1s in 2014, 2015, and onwards. We have really seen an explosion of checkpoint inhibitors and the benefits that they have brought to many different cancer types. And I think what this has raised awareness to is the fact that we can be harnessing our own body's immune system to deliver anti-cancer care, which wasn't the case before. We were always aware that the immune system was very important, but we didn't necessarily have ways of engaging it back into the treatment of cancer. And we have those ways now. Now, breast cancer is not necessarily an indication where the checkpoint inhibitor therapy is mainstream, but it is mainstream for many other types of cancer, such as melanoma, non-small cell lung, certain forms of colorectal cancer, bladder and renal. And I'm going to obviously not mention all of them, but for breast cancer, where this has taken some stride is in triple negative breast, which has been an area of great unmet medical need. And I'm confident that we are going to see further presence of immunotherapies, be this the first generation checkpoint inhibitors or many other immunotherapies in clinical trials today in the indication of breast cancer. Breast cancer, as we know, can be primary and secondary. And today we're talking about secondary breast cancer. We again then have subcategories within based on the expression of receptors, estrogen receptor, HER2, or the absence or presence of both of these. And we have seen considerable progress in the treatment of secondary breast cancer in each one of these categories in the recent years. In the estrogen receptor positive breast cancer, we have seen an introduction of CDK4/6 inhibitors, which are now given first line secondary breast cancer. And they really provide significant response and survival and quality of life benefit to our patients. They are oral therapies. We have 3 approved CDK4/6 inhibitors right now, and we're using them in combination with estrogen receptor targeted therapies. We have also seen great progress in the HER2 positive breast cancer space, with approvals of several antibody drug conjugate drugs. We have seen a recent approval of Enhertu in the HER2 positive space, which we now use following a previously approved antibody drug conjugate, Kadcyla. We also have another drug called tucatinib that has been approved for metastatic breast cancer that is HER2 positive. And we also have neratinib that was approved several years ago. Neratinib we can also use in the context of ER positive, HER2 positive breast cancer, so the triple positive disease. We have multiple anti-HER2 targeted therapies in early and late stage clinical trials, undoubtedly creating a lot of potential to have more lines of treatment available upon failure of the currently approved lines of treatment. We have recently seen a wonderful announcement of for the new antibody drug conjugate Enhertu, where they show benefit not only for HER2 3+ amplified breast cancers, but also for the HER2 non-amplified 1+, 2+ expressing breast cancers. And we can now obtain this drug through dedicated patient access program, which wasn't the case before. In the triple negative breast cancer space, we have recently had an approval as well of an antibody drug conjugate. And having the awareness of what is happening in the drug development space for breast cancer, there is really a lot going on. And not only are we investigating immunotherapies for secondary breast cancer, we're also really investing a lot in new chemotherapies, new targeted agents, which can be targeted to genomic drivers of breast cancer. And our previous speaker mentioned genomic testing, which I fully agree is incredibly important in our routine practice. And I also agree that we do not have enough access to it for every patient, and not enough access on a continuous basis. So we've got agents targeting, for example, the PI3 kinase mutations, and PI3 kinase pathway is an oncogenic pathway that plays a significant role in pathogenesis and progression of breast cancer, of certain types of breast cancer. And there are other mutations as well that ultimately we may be able to address therapeutically. Another avenue of great interest in the drug development space is combination therapies and a concept of what we call synthetic lethality, which in a nutshell means combining two drugs that work really well together, while one and the other individually won't necessarily have great efficacy. But when combined, they actually converge mechanistically in a way that actually produces clinical benefit. I have neglected previously to mention another category of drugs which has been serving us beautifully in the context of breast cancer, irrespective of the receptor status, but relevant to a mutation status, and those are the PARP inhibitors for BRCA1 and or 2 deleterious mutation carriers. And these drugs are, again, very well tolerated and have excellent efficacy in clinic. So we are really mindful of the genomic landscape and the vast amounts of data that we are collecting, analyzing, interpreting, and understanding. This takes time. And that is the truth of it. It does take time. It takes thousands and thousands of patients. It takes prospective clinical studies and following outcome based on actions taken. So I do understand how oftentimes in certain periods of time, we can perceive that there is not much going on. And then all of a sudden there is a tremendous progress with introduction of novel treatments. But I really can assure our patients and the community that there are tremendous drug development efforts going on in the background, and there is a lot of promise. I remember the year of 2001 when I was training at Jackson's Memorial in Miami. And back then, I remember us asking the question, what are we going to give patients after tamoxifen? Here we are 21 years later with more drugs than we could even count. So I really want to, as much as we are aware that this is a significant burden for the community, for the community at large, for medical community, for patients and their caregivers especially, I also want to emphasize this positive note that we have made a lot of progress, that the results are evident, and that there is more to come. Now, I believe that there is one aspect that we don't necessarily talk about too much, but that plays a very important part, not only for secondary breast cancer, but for primary breast cancer and every other cancer. And that is holistic care. How can we ensure that a patient comes to an oncology appointment and leaves with a little bit more than just a prescription, a blood test, and a scan? And there are beautiful conversations being introduced and held in the recent years, and especially probably since the pandemic hit and really brought to our awareness how much looking at a disease holistically is important: mind, body, soul, spirit, however we want to call it. And I really believe that that is really, that becomes an important pillar in the treatment journey of cancer patients who choose to incorporate that into their toolbox of care. And there are beautiful practitioners out there that are offering this type of care as well. So I will pause here. I know we have another 5 or 10 minutes left for this session, and I know we have questions, but I really did want to leave us on a positive note, acknowledging that there's lots more that can be done, but also with a reassurance that the medical profession and the drug development field are really looking into it.
Thank you very much, Alex. I mean, that's very uplifting talk, as I expected from you. There certainly are some questions. One, would you clarify the time needed in years to get these drugs that you've been discussing to the market? I know you said it was a long time, but so people are aware just what kind of time frame you're talking about.
You know, it really depends. For a drug to actually come to market, it can take anywhere between 5 to 10 years. It really depends on which cancer you're trialing the drug in. Breast cancer tends to be, because of the sheer volume and the incidence of this disease, our trials, especially phase 3 trials, really require a lot of patience. So it's not a clinical study that you can run in 200 to 300 patients and get an approval if the clinical trial hits an endpoint. You really do need probably north of 600 patients, and some trials need many, many more globally in order to be powered well, so that the results on the back end of the study actually have meaning and can be translated into an approval and into clinical practice. So because of that, trials can take longer, and usually between 5 to 10 years to approval.
Thanks, that's helpful. And kind of shooting off from that, there's also the question which Joe Taylor was alluding to, which is the thorny issue of including people with metabolic breast cancer in clinical trials, despite the fact they've often been on multiple therapies. And as we know, a lot of the early trials in particular don't like to have patients that are kind of confusing the results because of other therapies. So have you got any thoughts on that, how you can see a way around it, you know, how things are going?
Yes. So this really brings us to the innovative clinical trial design strategies. And more so than not, companies are now really implementing those innovative clinical trial designs. And that is reflected in really in different ways. One way is to do what we call an adaptive trial design, which means that you are building a protocol from the get-go that will allow you to even go to approval from that one protocol, if the drug is that good. Those are rare cases where you could actually execute it in that way, but it isn't impossible. There's also quite a bit going on with organizations, and I have to be honest, I'm not aware of one yet for breast cancer, but I do know that there is one such for pancreatic cancer and for ovarian cancer, where there will be a consortium of clinical trial sites in a certain country or continent. And a sponsor, a drug developer, will come in with a new drug, and they will enter a streamline within that organization with the new drug and use the standard of care comparator arm, which is continuously running through that consortium. So it significantly saves time and cost for drug development because you have the standard of care for randomization. And that is very appealing to sponsors, drug developers, because they save the cost on the standard of care arm. So these are really nice, innovative ways in which we're conducting trials. In the US, I'm not aware yet that the same scheme exists at the European level. It may, but I'm just not aware of it yet. But the FDA has recently instituted something called Project Optimus, which is their effort to ensure that drug development is done as best as possible for the patient benefit, so that we don't see doses of drugs pushed too high. And they're asking us now to investigate, to go into the broad clinical development and into phase 3 trials with the lowest dose that gives maximum efficacy, so that the toxicities can be minimized and also cost. So there's all these efforts now that are being implemented and that are really at play, which are making it easier to develop drugs and also faster than before.
That's helpful. Regarding immunotherapy, which clearly is a very exciting new development for all areas of cancer, and you've commented that there's been some work that shows that it works in triple negative breast cancer. Do you think that there's no data on the other, or no positive data on the other types of cancer at the moment because they've not been investigated yet, or genuinely there is a problem with current immunotherapies and the other types of breast cancer?
I wouldn't say there's a problem with the immunotherapies. Just every cancer is different. And immunotherapies have a specific way of action. They need certain immune cell types to be present within the tumor in order to work. And also, the reason why immunotherapy first has been trialed in triple negative breast is because it's the area of probably greatest unmet medical need within the context of breast cancer, because there isn't a targeted therapy yet. There's no HER2, there's no ER, and we don't have another equally well-established receptor and a biomarker or a drug target. So that's why immunotherapy went there first, and we have seen some positive data in combination with chemotherapy, both in the neoadjuvant setting, meaning before surgery, and in the secondary breast cancer setting. There are and there will be more trials with immunotherapy in the ER positive and in the HER2 positive setting, most likely in combination with existing therapies. The reason for that is that immunotherapy is by and large very, very well tolerated, and it combines really well with other types of treatment, both in chemotherapy, radiation therapy, and small molecules. So it isn't the end for immunotherapy in breast cancer by any means. I think it's just the beginning. It really is the matter of time and making sure that it's personalized, as it was brought up in the first talk. It really needs to be personalized, and that takes time. You know, developing a biomarker and a companion diagnostic, which means that you know what you're targeting with your drug and you know how you're selecting patients for the drug. That is a huge endeavor that usually goes unrecognized. It is incredibly costly, and it is not complicated. So whenever one, and it also is reflected in the fact that we really don't have many of those at all across tumor types. So it really, we're working on it. The community really is working on it. There's incredible research going on in academic institutions in the UK, across the world. What I'm really encouraged by to see in the previous years is the collaboration happening between biotech industry and big pharma and academic institutions to accelerate translation of what the academic scientists have discovered into therapeutic development. And that is, I think, an incredibly important avenue that we're witnessing and following.
Thanks, Alex. I mean, that's really encouraging, because I think, you know, there is a perception that not much is happening because people don't see all that. So that's really, really good to know. One just last question for you, and then I'm hoping Joe will be back. Somebody has asked about the place of food trials in cancer therapy, and also, well, I think she's also asked you to comment on lack of innovative therapy in breast cancer. I think you've already answered that very well. And then she's also asked about the use of, in the example she's given is an old schizophrenia drug as an anti-emetic, which worries some people, obviously, or why am I being given an anti-schizophrenia drug? So if you could possibly answer those, that would be great.
Sure. So I'll start from the back, from the last question. Personally, I'm not aware of that particular drug being given as an antiemetic, so I would encourage the patient to ask into that a little bit in greater detail, and perhaps even to give herself permission to challenge that, because we really do have excellent antiemetic drugs, and that particular one is not the one that I'm aware that we're giving as an antiemetic. So there may be other reasons or other conversations to be had around it as to why that one was suggested for her as an antiemetic. We don't usually give it, at least not where I have practiced over the years. Maybe it's given in other centers, but I truly am not aware of that. When it comes to food trials, there have been extensive food trials done for breast cancer, supplement trials as well, and not many have yielded any meaningful data that would change practice. Food, of course, is very, very important. It gives us nutrition, sustenance, and we also know that it is metabolized through pathways that some drugs also use to be metabolized. So we do have suggestions for patients, for example, when they get on some chemotherapy drugs and certain small molecule inhibitors, and we tend to tell them, please avoid grapefruit because it utilizes the same enzyme that the drug we're giving you will need to get metabolized. So you don't want the two competing. And then each one of us is different, and each one of us will have a different metabolism also. So it is not a one shoe fits all type thing. Oftentimes, when there is a breast cancer diagnosis or any cancer diagnosis, typically the first thing that the patient will go to change is their dietary regimen. And I do fully support that. And I often just like to say that if there is a massive change in a dietary regimen, a massive exclusion of something that was previously present, and equally, you know, an introduction of something that your body has never seen before. That can represent sometimes more stress on the body than give immediate benefit that one is looking for. So I still tend to advise everything in moderation. And if you're introducing changes, then do that gradually. And I do support that always, because the patient knows their body best. So I really try to encourage that empowerment of the patient for the patient so that they can act from within to know what's best for them. And that also tends to be sometimes linked to cancer. Can often feel as if I don't have any control. I can't control this. And then food is something I can control. So there's all these different facets when it comes to food that we need to look at and have an open dialogue with the patient about. And that's where the holistic approach comes in.
Thank you very much, Alex. That's been really helpful. We're going to have to stop here, unfortunately, but that's been very, very useful advice. I'm sure everybody will agree with that. Jo, are you back now?
I'm back.
Oh,
sorry.
Good. Okay, so
I'm really sorry that I missed.
No,
it
worked very well, the video. It was excellent.
Thank you. Sorry.
One question which I think would be best addressed to you. Sorry, I'm joking now. It's actually from a lady in Denmark, but I think, you know, you might well have some thoughts on it. It's about patient advocacy and how do we influence politicians to, what she's put is upgrade our breast cancer packages and precision medicine, but it's really kind of things you spend a lot of time, I know, demanding, and for both for yourself and both for the community, you know, relating to personal medicine and the whole lot of things. So what are your thoughts on that?
I think there are a lot of issues to do with, you know, who is listening to us at the moment. And I think you've got to cover as many bases as you possibly can. This is what I'm finding at the moment. Speak to everyone you possibly can. Get your voice out there to everybody you can speak to. I was just actually on a call to NICE. That's who I had a Zoom with. And this is about drug approvals, about, you know, how to advocate as a group to submit evidence for drug approvals with NICE, with the SMC, because we've been doing that over the past few months since we became a charity. Only in December, we're now a charity, Met Up UK is. But yeah, I mean, I think you have to get out to as many people as you possibly can. MPs, get into clinical people, clinical trials, researchers. I speak to as many people as I possibly can, advocates, communities, everyone, to raise that awareness and the issues around secondary breast cancer. We had a great campaign last year in October, and it was called the Darker Pink campaign. And we had 31 images, 31 figures depicting 31 women who die every day, and there was 31 days in October, and it was an art installation. They had QR codes on there, and I'm trying to get that now possibly into Parliament, and whether we can get them into kind of an area where MPs will see them, because again, we're invisible, and this is what has been highlighted a number of times by, you know, campaigns like from Breast Cancer Now, you know, the invisibility of secondary breast cancer, because it's all very pink and fluffy. And everybody thinks everybody lives well with breast cancer. Well, you know, there's a number of us dying every day. 31 people die every day. And that message really needs to be hammered home. You know, it's not a figure that, you know, can be just ignored. 11,500 every year. I would say just speak to everybody, raise your profile, speak to anyone and everybody you possibly can.
Thank you very much, Jo. I mean, there's lots more I'd like to ask you, but unfortunately time is against us. But I just want to say before Jo finishes that she has got this book out, which is available either in Kindle or hard copy free, which is incredible. And it's very, very useful book for anybody with breast cancer, and particularly secondary breast cancer. And the details will be available with this talk. And it's also on her ABC Diagnosis website. So thank you, Jo, and thank you, Alex. We're now going to move on to session 4, which is site change again. So this is looking really at the way forward post-COVID and recognising the fact that people are now living with secondary breast cancer. And so is some of the terminology used really quite inappropriate? And we've got 3, again, excellent speakers for this. We've got Dr. Chris Twelve, who's an oncologist from Leeds, and I went to medical school with him a long time ago, but that's another story. Alfred Newgate, who is Professor of Cancer Research and Epidemiology at Columbia University Medical Center. And we've also got Professor Mike Dixon, who is a breast surgeon up in Edinburgh. So starting with a mini panel with Chris and Alfred.
So I guess that's me starting. Okay, thank you. Thank you for that rousing introduction. Good morning from New York. So let me start by saying this is a lovely panel. I enjoyed listening so far. Let me say that I think what's very important is how we communicate. I think all of us can appreciate that. There's a lot of money being invested besides drug development, how physicians and healthcare workers communicate with their patients. I'll give as an example, something that I've been interested in is, for example, should we say to patients, the risk of recurrence of your tumor is 20%, or you've got an 80% cure rate. Which will a patient appreciate more or react to better or understand better when she thinks about how to react to how to be treated or what to do about her tumor or how will it make her feel. And the truth is that hundreds of thousands of dollars in research money has been invested by the government in analyzing that question. And if you're curious, the answer is the answer to that research question is it depends on the patient. Sometimes it's better one way, and sometimes it's better the other way. So the truth is that communication is an important part of what we do in oncology. And that brings me to the next point, which is that nomenclature, the words that we use, are very important. And I would give in this talk, I hope, 2 examples along with Chris to discuss. The first is the use of the word palliation. A new specialty has arisen, I think, in the last 20 years. I've been an oncologist for 40 years, but in the last 20 years, palliative care has arisen as a specialty. It's a wonderful specialty. I love it. It relieves me and my colleagues of much of the burden of taking care of many of the supportive care issues with my patients in terms of caring for some of the supportive care for them. One issue with that is when to refer a patient to palliative care, a patient with metastatic breast cancer. You've been all using the term secondary breast cancer. I'm not actually sure we don't use that term in America. I'm not actually sure what it even means now that I'm listening to the panel use it, but I assume it means metastatic breast cancer. But So in that regard, my colleagues are very reluctant to refer patients to palliative care physicians because patients are reluctant to go to them because they think if you're being referred to a palliative care physician, we've given up on you. And the truth is that as a result, patients are referred very very late in the course of their disease to a patient when they're very near the end. And I think that's very unfortunate. And part of the reason for this is that the term palliation has a very pejorative and very pessimistic and very negative implication to it, to patients, and I suppose to my colleagues as well. And perhaps that's even accurate. I don't want to say no, but that's still an unfortunate thing. But that carries over into its use also in treatment, which is in the 1950s, when chemotherapy was starting up, particularly for solid tumors. There were two kinds of chemotherapy. One was curative chemotherapy, and if it wasn't curative chemotherapy, we referred to the other type of chemotherapy for patients, say, with metastatic disease as palliative chemotherapy, because at the time, chemotherapy for metastatic disease was basically not very good. And so the best one could hope for was that it would make symptoms better, make the patient feel somewhat better, perhaps improve quality of life. So it was given the term palliative chemotherapy. We stand here today, 60 years later, and we are still using the terminology palliative chemotherapy for any chemotherapy, which is non-curative. Now, 60 years later, I think all of us can agree that chemotherapy has moved forward a great deal. Many kinds of what I'll call palliative chemotherapy are much better than they were in the 1950s. Many diseases, breast cancer, colon cancer, multiple myeloma, chemotherapy for them has, if not curative, at least it's very much life-prolonging chemotherapy. People live years with metastatic disease. So to continue to use a term like palliative chemotherapy for that kind of treatment is really giving it a much more pessimistic and pejorative implication and assignment, which I think for a patient is a very negative thing to do. And I think we should move away from using that terminology in that context now that we're now that it's no longer a terminology that really applies. Let me throw the gauntlet or the I don't know, what do they say in the Olympics? I'm giving the baton to Chris and let him say a few words about this. Chris?
Thank you very much, Alfred. It's a pleasure to meet you, albeit virtually. Alfred and I have discussed this issue over some time, but not actually met. So I'd agree with everything that Alfred said. And I think during the 50s and 60s and into the 70s, the use of chemotherapy was quite difficult. Patients with metastatic disease had a very difficult time. But interestingly, at that point, there was relatively little, unfortunately, relatively little discussion with the patient about what we could and couldn't do. And although when I was training 35 years ago, we certainly never sought to mislead patients, there was a school of senior oncologists at the time who would tell patients that things were going to be okay, would allow the patients to maybe have a more optimistic outlook than was perhaps likely to be the case. This changed during the 1980s when there was a move amongst some of our colleagues to be much more honest with patients and admit the limitations as to what we could do. And in that context, the use of the term palliative chemotherapy at that time was quite useful because it was a recognition that we couldn't work wonders for many of our patients with metastatic disease. But as Alfred, that admission was actually quite controversial. I remember being at a meeting some 30 odd years ago when a very senior oncologist said she thought it was outrageous that we admit to patients that we couldn't cure them if they had metastatic disease. But now I think we are much more transparent, we're much more straightforward with patients. But what has changed now is that most patients with metastatic breast cancer spend a significant length of time, I know this is a simplification, but living with their cancer rather than dying from their cancer. Or certainly that would be our aim. And in that context, where certainly for people with metastatic breast cancer, where they may live with their cancer for several years, using the term palliative in that context doesn't quite feel right. It has that association with palliative care, but also we use the term palliative in our clinic letters, and of course, increasingly these days, we send out our patients copies of the clinic letters, so patients are seeing a terminology which may confuse them. So certainly, I would favour as thinking of metastatic chemotherapy, and it is generally metastatic disease, as being a non-curable chemotherapy, non-curative chemotherapy. I wouldn't, if you like, want to outlaw the term palliative chemotherapy, because there does often come a time when patients have exhausted a number of lines of treatment where there is a decision whether or not chemotherapy is medically appropriate or whether symptomatic measures may be better. And there may be situations where chemotherapy may be seen as on a par with analgesics or antiemetics to control symptoms. And perhaps if we changed from the non-curative to the palliative notation for chemotherapy, that would also be a prompt for us to make that transition towards palliative or supportive care, and to acknowledge that that was the phase of the illness that the patients had now reached. But this is something that we've discussed. We're just keen to have a wider discussion. I did look before coming here at our chemotherapy, our electronic chemotherapy prescriptions, and it gives the prescriber options as to what the intent of treatment is. And the options that we have are curative, palliative, non-curative, disease-modifying, and radical. And I think that's unnecessarily complicated, and that we maybe could find a terminology that we could agree on as obviously with patients, carers, and healthcare providers, that was a little better reflected the type of care that patients hopefully experience these days.
I would add to that so my proposal, in the paper that I wrote, was that we categorize it into three categories, which would be curative, which we all understand, which would perhaps also include adjuvant therapy, neoadjuvant therapy, but also, and that we subdivide for metastatic disease into life-prolonging therapy and palliative chemotherapy. I would agree we should keep palliative chemotherapy when it's really being used for palliation, as opposed to, for the most part, life prolonging. But also it makes it more transparent rather than vague and ambiguous. So that's what I would, again, if we talk about radiotherapy, for example, we sometimes use radiotherapy as palliative radiotherapy. For example, when someone has a bony metastasis, which is painful, there's no implication that it's curative or whatever. It's really purely, we use the term palliative radiotherapy in that context, and I think that's a very clear, accurate, and appropriate terminology, and we should use it in chemotherapy in the same context with the same terminology. If I may, let me switch to another example of ambiguity, I think, or a misuse of the term. And again, this one I haven't thought through that much, but I'll throw it out to the crowd and maybe to Chris, again, to comment on, which is ambiguity in the term metastasis. Again, another term that we use all the time. It strikes, I think it's a term which is obviously a very concerning term when a patient hears it, a patient who understands the term and what its implications are when they have this disease. But again, metastasis, of course, is spread of the tumor away from the primary site. But again, we use the term metastasis in two contexts. One is metastasis to distant sites, liver, lung, bone. I'll use it here in the context, let's say, of breast cancer, since I didn't realize that this was going to be a breast cancer conference, but obviously that's as good as anything else. But again, we also use the term metastasis for spread to local lymph nodes. So if a woman has a spread of her breast cancer to her axillary lymph nodes, and in which case she's, let's say, stage 2 as opposed to stage 4, the same terminology is used by the pathologist in their reports. So that's called metastatic spread to lymph nodes, the same term. Now, if a patient reads their pathology report and sees that they have metastasis to lymph nodes, if I weren't a sophisticated woman, a sophisticated layman, and I saw that terminology, I think that would strike terror into my heart to see the word metastasis being used there. But the truth is the implications are much less severe. Not that they're good necessarily, but they're not the same as metastasis in the way we normally think about metastasis. So I think, again, that this is an area where we really have to dichotomize the term metastasis into two different terms, something that and to restrict the term metastasis to distant spread or to stage 4 disease, where we understand it and its implications as being ominous, and to give a different terminology for local metastasis to lymph nodes, where it's really a much less severe problem. And I have not yet, I'll be honest, I have not yet come up with a term to use. I don't know what term we should use for local lymph node, or I guess spread is a term that's used sometimes, but I'll leave it to Chris or to someone else here to come up with a term or to think of. But so again, I'll pass the baton back to Chris again.
No, I think that's an important and relevant point, because again, in the context of breast cancer, when we're talking solely about spread to the local lymph glands, we're hopefully still in the potentially curative setting. Whereas when patients have got more widespread metastasis, we're invariably talking about non-curative treatment. So it's a black and white situation in many ways in terms of the nature of the conversation with patients, and I can imagine it being difficult for patients to reconcile the use of the word metastases in these different ways. As you say, I think it's the difficulty is that they are both metastases. It's the addition of the word distant, isn't it? And I'm not sure whether that makes it clumsy or whether we'd be better using the word spread, as you say, for the more local disease.
Can I intervene at this point? Because unfortunately time is our enemy, and I'm aware that Mike Dixon has to leave pretty promptly. So Chris, is it all right if I bring in Mike?
Of course.
And then we'll continue this discussion in the Q&As at the end, because it's very important, clearly, and I'm sure there'll be a lot of interest. So Mike, can I hand over to you, please, for your talk, which is the last word, post-COVID issues and breast cancer moving forward. Are you on mute, Mike?
Hold on, can you hear me now?
Yes, thank you.
Sorry, I've got so many things on my screen at the moment. Let me just, I've got some other garbage come up now and send large files. I'm going to try and get that off my screen. Just let me, right. Just suddenly got WinZip wants to come up and take over my screen. I don't want to, I'm trying to share my screen, and it's wants me to buy WinZip in the middle of my my talk here, which is crazy. Let me try again, see if it will let me, right. Can you see my screen?
We can.
Right, okay. So I just wanted to, we've had a tough time in COVID. I want to talk a bit, I was asked to talk about a bit about the voluntary sector. So, you know, the impact of COVID on breast cancer services has been significant, and not necessarily for the right reasons. And, you know, we're all going along doing lots of cases, and then suddenly COVID came along, and you see this is like what's happened to the economics and what's happened to all the cases. And I was kind of surprised, shocked, and really disappointed that that there was I have to say in Edinburgh, we stopped nothing during COVID. We've continued regardless, and we've had no problems. But ESMO said that low priority groups were follow-up of patients at high risk of breast cancer. So these could be literally shelved for a while. Psychological support visits, and of course, that was transferred to telemedicine. But of course, many doctors actually weren't available to these patients for psychological support visits. They stopped population breast screening. We weren't allowed to do any breast reconstruction with flaps and implants, although we continued to do some implant reconstruction in Edinburgh. The plastic surgeons didn't want to do anything. I actually had to record a series of videos for Macmillan telling patients why they wouldn't be getting their reconstructions. We weren't allowed to do risk-reducing surgery. And they were even saying that low-risk groups were elderly patients with ER-positive breast cancer. You could just keep them going on letrozole. We often put a lot of these patients on letrozole for a while anyway. And patients with DCIS. So it struck me that there's a lot of groups here that they consider low priority, and that really we could almost ignore these patients. And there are consequences of that. This is actually work from Croatia. And you see here that this looks at a number of patients they were seeing monthly. And you can see here, this is there's a red line, red dotted line averages things out. The blue dotted line is what they were doing normally. So they were at a slow, steady increase normally, but you can see here, it's quite marked shift down in April, May, in the first lockdown in Croatia. And you see by the end, it was, you were getting more and more patients referred. Overall in the UK, there's been a 15% reduction in, this is actually a study, another European study, 15% reduction in breast cancer cases seen in this European centre during COVID. And sadly, they were seeing patients with larger tumours, greater numbers of involved lymph nodes, more de novo stage 4 disease, and increasing patient delay was really due to that fear of transmission and lockdown. We had a lot of patients, even though we were seeing normal people in the clinic, a lot of them were panicking about coming in. We almost instilled this sense of fear in people. The impact on breast screening, according to Breast Cancer Now, there's more than 900,000 fewer women were screened in the year up to March 2021. And that reduction in screening led to a 39% reduction in the UK in breast cancer diagnoses. Of course, what we found out is that COVID and breast cancer don't really interact. Breast cancer patients had less complications and lower mortality than many other groups in the cancer with different cancers. We didn't see any excess complications, but sadly, treatment was amended. And the good thing is that the treatments that we were giving, it was clear, had no impact on COVID infection rate or complications. And it's intriguing, during the whole time of lockdown, none of our staff developed COVID. Since we've come out, we've got Omicron, loads of people have had it. But during the time when everybody else was locking down and doing nothing, we were gaily carrying on. And we never run into any problems, and neither did our patients. And we shouldn't have changed our approach to treating patients. This is the sad news. Look at the impact of COVID-19 on breast cancer mortality. And I think one of the most depressing aspects of COVID is that the people who were leading us were blinkered. They saw COVID deaths and they had no idea of the other deaths. And they didn't look on the shoulders of giants like the man who saw the apple falling from the tree, Newton. You know, you've got to look beyond and above what's in front of your eyes. And this study from the United States, by 2030, their models predict there are 950 excess breast cancer deaths related to reduced breast cancer screening, 14 deaths related to delays in diagnosis of symptomatic cases, 151 deaths related to less use of chemotherapy during COVID, a total of 2,487 excess deaths, or roughly 0.5, an increase in the deaths from breast cancer of about 0.5%. And this looks at the different numbers of deaths that they would be expecting up to 2030 above. So this is just skip screening This is skip screening and delayed diagnosis. And this is the minimal effect of not having so many patients getting chemotherapy, because these were mainly the ER positive patients. And sometimes you get it wrong, and I don't know if you can hear the sound.
What O is the generic word for any living animal or plant, including bacteria and viruses?
Orgasm. Oh.
So I don't know if did you hear that?
Just about.
Good. So what he said was, what O is the name for any living organism or plant? And he said orgasm. And of course, it should have been organism. And that's the fact is, we really got it wrong. The thoughts of Macmillan is that there are 50,000 missing breast cancer diagnoses, and the government must act now to tackle the backlog. And we must ensure that this doesn't happen again, and never again should be the forgotten sea. So the fallout for us and for many units is a backlog of patients to be seen. There's increased wait for clinic appointments. So we aren't seeing patients in many centres for 4 to 6 weeks. There's delays getting reporting and scans and pathology, because actually the people in labs are off, and many people have left because the stress of everything that's happened has actually been too much for them. Huge backlogs and reconstructions and revised ops, increased demand, but there's no increased funding. We've heard the government plan out what we're going to do, but I don't think we've actually heard anything that's actually going to make an improvement. And of course, there aren't enough staff. There's so many jobs that are available, and we haven't trained enough people. We haven't planned. And rather sadly, and I see it every day, I've never done any private practice. And it's really sad that patients now patients who aren't privately insured are going to the private sector to get their lumps diagnosed. And then the problem is what happens when they've got cancer. They then come back in to the NHS system, and that has an impact on NHS patients, because they get bumped further down the line in many centres. And one of the things that's been very clear during COVID is the voluntary sector were themselves hit, but actually so many more patients needed information, support, because they had no psychological support, because the psychologists weren't there because they weren't working. Against this, you need to understand that we have, sadly, a failing NHS system. I've worked for the NHS a long time, and I've never seen it in quite as big a mess as it is now. Let's look at the impact of the COVID on the voluntary centre. So this looked at, as your financial position deteriorated, this is 1 month during COVID, as the financial position of the voluntary organisation, 697 respondents, as it made worse over the next month. You see here 39% in this COVID period, their financial situation deteriorated. The range of service you can offer over the next 6 months, over 40% were saying they've been able to offer decreased services. The financial position over the next month, you see here deteriorate. Demand for services, you see this mismatch between decreased revenue and increased need. And this is really the sad thing is, what's the likelihood of your organisation no longer operating this time next year? Very unlikely, quite unlikely, but very likely and quite likely. And we see the breast cancer haven, quite a few breast cancer voluntary organisations are either no more or have had to make massive changes. And the expected impact of COVID on delivering objectives next year, significant impact, 37%. So what is the future? Well, we need these voluntary organisations more than ever. And somehow we need to get them back on their feet. Somehow we need to get all these groups funded again. You see here the breast cancer haven down there, they're in trouble. Maggie's and the secondary breast cancer group are in here, should be in here somewhere as well, because they're very important. And so we need more and more people to help, because volunteering is a superpower. We have to get innovative. I thought this was very good. Wear it pink. Bet you didn't expect to see this pickup truck is wearing pink, and we didn't. But that's what we need. We need innovative and new thoughts. We need. We've got the voluntary sector plays such an incredibly important part. They're filling all the holes in at the moment because there are many holes in the NHS system. Everybody will have their own list of the roles that the voluntary sector plays. They lobby on behalf of patients to get more money, and we need more lobbying than we ever have because the system is in real trouble. Provide information, advice, work in partnership with the NHS to provide needs. And they continue to improve outcomes through funding research. So somehow we have to, in combination with the voluntary sector, get through this difficult period. But we've got this huge backlog. We don't have enough doctors. We want more and more of the voluntary sector. And of course, in many of the voluntary sectors provide all the hospice care as well. So I think, Houston, we have a problem.
And like that, he's gone.
Thank you very much, Mike. A very sobering but important talk, and appreciate that. So we're fighting against the clock now. There's a couple of questions that have come in from patients who appear to be quite desperate to get some kind of answer. So I'd like to just start with these first. And this is the panel, Chris and Mike and Alfred. And I think, Chris, you've probably been prepared for these. One of them is from a lady who's asked twice about using B17 and turkey tail mushroom extract. Now, she happens to have lobular breast cancer. I know you can't really discuss about individual patients, but have you got any particular thoughts on turkey tail mushroom extract and B17?
I don't. These sort of requests and discussions come up quite frequently with patients. The concerns that I have are, I guess, firstly, that in a number of cases, these can be quite expensive, and I'm concerned if something for which there really isn't any substantial evidence is being used as a means of making money. And I think there is always the concern that if we say that they're safe because they're natural and therefore they don't have any effect, it's difficult to marry that up with them having a biological effect on the cancer. And if they are interfering or changing our metabolism in some way, then clearly there's the concern that this may be negative rather than positive. And there have been some isolated examples where that has been the case. So I tend to be very cautious. It's a different question, but one that I've worked with quite closely around the use of cannabinoids in cancer. And there's a huge literature on cannabinoids. But when you drill down into how much of that is actually substantiated or has been described in an accurate way, a lot of it is potentially misleading. So I tend to be rather wary.
Thank you.
So perhaps I could comment briefly as well.
Please, yeah.
Because I did a lot of work in trying to find out what alternative therapies are beneficial and what aren't. And in fact, we even sort of Chinese medicine. I was involved with people in the United States where they actually took Chinese medicine, and because they tend to be groups of things and even when you dissect out and look individually at the individual components, it's really very difficult to show a benefit. I also think it's really important not to confuse the fact that there's a lot of literature and a lot of information on these drugs from supporters and with evidence. I'm somebody who is completely open to everything out there, but the studies that I've seen show that if you look at the survival of patients in relation to their diet, it's a U-shaped curve. And the people at the bottom of the U who do best have the best balanced diets. And when you look at survival the difference, people who have an excess of something or a lack of something. The studies, they've looked in fairly great detail about diet, of not being able to show that taking something that's not normally in your diet to excess, or reducing something from your diet that's there, improve outcomes.
Thank you. That's again really helpful. Thanks, Mike. Right, and another lady has asked, she's got secondary breast cancer, and she's asked a series of questions. The first one is, why are invaded lymph nodes not always removed? The second is, why don't we do a full body scan, including the brain, from the beginning? Because there might be metastases there that we can't see. She's had an experience where her PET scan missed multiple areas of bone metastases. She's asking, how can that happen? And she's been told to have a CT scan, and how can that show up metastases, whereas the PET scan can't? So that's a group of questions, if somebody can come back on that.
Mike, do you want to take the lymph nodes?
Yeah, so like the patient at one time, I was convinced that if you removed both the lymph glands, they would do better involved lymph glands. In fact, study after study after study has shown that whether you remove some or all the lymph glands, surprisingly doesn't make a difference. Now you say, well, how does that, leaving disease behind, how does that work? Well, actually, in patients with cancer who spread, the body in some of the patients actually copes with the cancer cells for years and years and years. We know that because some people recur 20, 30 years later, and that's been in that those cancer cells have been there. So actually it turns out that leaving some of the lymph nodes is not always a bad thing. And sadly, there's this belief that if you remove all the cancer you can see, that's going to improve the outcome. And that makes complete and total sense, but actually it's not being borne out in studies. So the American study where they did a central lymph node biopsy, if the nodes were positive, they just left the axilla alone. The patients who had all the lymph nodes removed did no better than those whose nodes had some nodes left. So it's a conundrum. We don't really understand it, but the fact is that radical surgery, doing more radical procedures, has never been shown to improve outcomes.
And at least part of the problem, of course, Mike, is that what is a problem, what is lethal for most patients who we lose with metastatic breast cancer, is that they had invisible occult metastatic disease when they were first diagnosed. And that doesn't go away by taking an extra lymph node, unfortunately.
That's true.
The question about the different types of scan, I think it reflects the fact that these are, as I said, different types of scan. CT scans are quite good, are probably the best in terms of the granularity. In other words, the amount of detail that you see if you want a scan to look at much or most of the body. PET scans don't show as much detail, but what they can be useful at is if the CT scan or another scan has shown a shadow and we're unclear whether it's cancerous, because cancers tend to gobble up sugar. If you do a PET scan with a radioactive sugar, then the lump that is cancerous is likely to light up because it's gobbling up the sugar. The lump that isn't cancerous is less likely to. But the amount of detail you get in terms of how tiny the lumps that you see are, that isn't as good with the PET scan. The other type of scan that women with breast cancer, metastatic breast cancer, may have are bone scans. And these again are injecting a radioactive tracer, and that radioactive tracer homes in on areas where there is bone damage. Now that in somebody who's got breast cancer, that may well be due to bone metastases. But if you have an injury to a bone, that can also show something, an increase in uptake. So these scans need to be used in their particular situations and depending what the particular question it is that we're looking to answer.
Thank you. I just say that if your cancer's not happens to be gobbling up glucose, if it's not particularly active, then it won't show up on CT. So you can see, as Chris says, not one test is good for everybody.
Thank you. That's really helpful. Now we're in sort of minus time, but for maybe the last couple of minutes, I'd like to go back to Chris and Alfred's talk, and it's kind of, where do we go from here? I mean, I think the points brought up in that talk were excellent, and a lot of the chat comments were coming up with similar approval, really. So if we're not going to call it palliative breast cancer, how do we make that change? And Chris and Alfred, do you have any thoughts on, how we can make this happen?
Well, Alfred has published a seminal paper on this about 2 or 3 years ago. I can't remember how I came across it, but he articulated many of the thoughts that I'd started to have. So I think Alfred and I had decided that following this, that we'd look at how we might take this further forward in terms of whether we canvass patient groups, whether we canvass our colleagues, and look at how we may make this change. It is largely coming from the use by the medical profession. So we would value people's, the public's perspective on this, but I think it would be the medical professionals who we would need to convince to change. Alfred.
That's great. Sorry, Alfred, go on.
No, that's true. I mean, I don't know exactly how you get people to change their language or to change terminology exactly. It's by utilizing it in papers, in the literature, and then people will adopt it more as time goes by. That's a slow process. I think people don't like to change the words they use so easily. It doesn't happen. Sorry, it doesn't happen overnight, but we will say life changes, so words change too. So we'll see what changes down. I saw on the chat line, someone said that they've used the term secondary for second primary breast cancer, contralateral breast cancer, for example. That's what I thought when I first heard someone refer to it. So that's also an ambiguous term as well for me, at least it was for me. And so lots of things are ambiguous sometimes. Mm-hmm.
I'm so sorry, guys. We could carry on talking for ages, but it's now coming up to 3 o'clock. So first of all, I want to thank Gerard and Pink Ribbon for organising this conference. And he always manages to get excellent speakers, and he has certainly not failed this time. I also want to thank Pfizer for sponsoring, and very much thank Anna and James for all the technical help, which has been amazing. Thanks so much to the speakers. You've all given up your time and really produced some very interesting and excellent talks. And thank you to all the participants who have also really connected. There's been so many things on the chat, and I'm hoping people can go to the chat and look and make connections with each other, because I think there's a lot of useful things that can come out of this. Gerard, can I hand over to you?
Well, not really, Kath, because I think you've summed it up brilliantly there. I mean, thank you to absolutely everybody from contributing from all over the world. I mean, we're happy to help promote any of the questions, points, issues raised today. For example, the terminology point at the end. If we want any input from the patient community, then we can do that. Chris and Alfred will pick up the baton there a little bit if we can run for half a bend on that. But apart from that, just to echo, thanks to all the brilliant speakers. Thanks to Dr. K for chairing so excellently as always. And thanks also, I guess, to every single attendee, above all, for coming and spending and sharing a little bit of time this afternoon. And I'll just echo that thanks to Anna and James as well on the technical side. And God bless and goodbye.
Bye, everybody.
Thank you.
Ciao.
Ciao.
Arrivederci.
Arrivederci.